dear members of the Pediatric Cardiac Society of India. It is indeed an honor to be here as the president of our August Association in this 22nd annual meeting of the PCSI. In 2022, as in 1999, when the PCSI was set up, the PCSI still remains an equal platform for its constituents, which is the cardiac surgeons, the pediatric cardiologists, the intensivists, and anesthetists. And it is to the credit of the platform as well as the constituent members that this continues to be the case. Many other organizations have been set up as combined organizations and have separated out, but the PCSI remains as a common platform for all people looking after children's hearts. And that is a great thing. Dr. Rajan Tandon was the father of this PCSI, and he conceptualized it in 1998, and it came into being in 1999. However, being here takes my memory back to the time when I was first interacting with Dr. Rajan Tandon, which was many years before the PCSI actually came into being. And this was actually when I was an intern. When I was an intern in the sweltering heat of New Delhi, I used to go to the cardiac clinic just because of my fascination for cardiac murmurs. And I used to go to his chamber in the clinic. He had an air-conditioned chamber, which was an attraction in Delhi in the summers. And also it was completely soundproof chamber, if people who from that time would remember. And he had that huge double tube Rappaport Sprague stethoscope, which he would evaluate, and he would give diagnosis basically based on murmurs, ECG, and X-ray. Echo was not that well established then. Cardiac catheterization was done, but basically the diagnosis was by far clinically derived. And so my fascination with the stethoscope took me to Dr. Rajan Tandon's clinics, and I would look for this continuous venous hums of TAPVCs that he would pick up, and probably I would imagine them more than I could hear them, but it was truly fascinating. That same fixation for the stethoscope continues even today, and I find that I am auscultating my postoperative patients more than my cardiologist does to look for any residual defects, and I actually lay more precedence to a systolic murmur if it's there or not. And a cardiologist may say there's a VSD, but if there's no systolic murmur, I'll say it doesn't really matter. So that habit remains. During these clinics, I spoke to Dr. Rajan Tandon, and he was quite brusque, and I mean maybe to this intern who was stepping probably out of his line, and I took his advice in whether I should do my MCH, 5-year MCH, which had recently started at that time, or whether I should go in for 3 years of general surgery and then go in for cardiac surgery after that, if I wanted to. And he suggested that I should not put all my eggs in one basket, and I should go for general surgery first. And I took his advice and I did my general surgery. In general surgery, before I could even touch a knife to a patient or hold a needle holder, I was sent on a rotation to cardiac surgery, the Department of Cardiac Surgery. And in cardiac surgery, since I had not done any surgery, I was just attending rounds, staying the nights for night duties, doing dressings at 5 o'clock on the 5th postoperative day, the 7th postoperative day, which is routine in postoperative patients. And basically, and these used to used to happen at about 4:35 in the morning. And I used to just wake up and help the senior residents do the dressings on the 7th floor of the All India Institute. As some of you would know, Dr. Venugopal was in the habit of coming in the morning at about 3 or 4 o'clock in the morning rounds, at 3 or 4 a.m. And he found this fellow who's doing dressings at this odd hour in the morning. He probably noticed me out of the corner of his eye, but he did not mention anything. Few days later, he just burst through the door of the open heart room, and he interrupted a quarrel going on between two of my senior residents, which was, I still remember, Dr. Nazar and Dr. Pawan Kumar Pepara, and they were arguing over who would do the ASD the next day, the patient who was posted for ASD closure. Dr. Venugopal said, you guys are, neither of you are going to do it. This fellow is going to do it. So before I'd even held a needle holder or done any other surgery, I was the next day standing on the right side of a patient, about a 15-year-old girl. He was standing on the left side. I had a headlight on my head, and he helped me do the incision, the midline incision, the sternotomy. So my first day of surgery in cardiac surgery in operating room, scrubbing up, I was, basically did a sternotomy. Obviously, I could not do the different steps of the operation, and he basically did the operation standing on the left side. But when the right atrium was open, I know I closed the ASD myself. So it was a direct closure, and I went up and came down, and so this is Dr. Venugopal, and basically Dr. Rajan Tandon and Dr. Venugopal were basically therefore responsible in getting this guy, who was basically a medicine-oriented guy, who was interested in heart murmurs, but basically getting him into surgery. And my first operation actually therefore happened it was an ASD closure in my first year of junior resident general surgery in 1984. I actually joined MCH in much later, 2 years later, and in my MCH program, this is a picture of when Dr. Venugopal was given the Lifetime Achievement Award in a prior PCSI, and on either side of him is I and Dr. Anil Bhan, and we were very close compatriots, both of us, spending long nights in the ICU in 3 into 365 into 24 hours of the 3 years that we spent in MCH was spent in the ICU non-stop. On one such round, he asked, who of you have done your ECFMG? And he was just back from a conference in Bergamo in Italy, a pediatric conference where he had met Dr. Aldo Castaneda. And I was the only guy who had done ECFMG. And he said, okay, you fill up these papers and you send them to Boston Children, Dr. Castaneda's address. And so a fellowship was set up, a fellowship in Boston Children, followed by one with Dr. Subramanian in Miami, Florida. He had trained himself with Dr. Subramanian in Buffalo. So this was how a person who had no interest in cardiac surgery, got hooked onto cardiac surgery and has remained in this line till this time, and going deeper and deeper into that niche and never being able to get out of it, for the good or the bad of it. So that's how one particular individual got into this line. And I'll tell you the relevance of this a little later, in my view. When I was in Boston, there was Dr. Richard Jonas, who was also a consultant there, and he was a little partial to people from the subcontinent because of his likeness for cricket, I think, and we used to discuss cricket over rounds when nobody else understood cricket in Boston. And then subsequently, when I came back and started operating on my own, if I had difficulties, I've been in touch with him, and he was very helpful with his suggestions and solutions. Back in 1991, I got back into the All India Institute, and these are the faculty members who were there at that time: Dr. Venugopal, Dr. I.M. Rao, Dr. Babadas, Dr. Iyer, Dr. Balram, Dr. Sampath, and I am deeply indebted to all of them for all my development that happened once I was back, because basically my learning actually happened when I got back from the fellowship. And I got back and became a consultant, and that is when I basically started learning pediatric cardiac surgery, which I had observed in these two fellowships. The pediatric cardiology faculty were Dr. Tandon was there, Dr. Srivastava was there, Dr. Kothari, Dr. Anita Saxena, and my very good friend, Dr. Juneja. Dr. Juneja had recently joined there, and basically, we were very reluctant to call Dr. Kothari and Madam every night because we always suspected the shunts getting blocked. So ultimately, it fell on Dr. Juneja, and he became really good at echocardiography. I think thanks to us in the beginning, because the first time he said it, he diagnosed an SVC flow as a patent shunt, but the shunt was blocked. But after that, his diagnosis was always very spot on. So this was the Department of Pediatric Cardiology, and I'm indebted to all the members of this department for my development in this line. Uh, and this is a typical day in the office for all of us surgeons, and this has lasted from 1988 to now. And basically, you get on into the operating room, put on your headlight, put on your light, and you get out probably by evening or afternoon. And that's what constitutes a typical day for a surgeon. Now, as Devashish told, Dr. Devashish said, I've had the fortune or misfortune, whichever way you might take it. Everything has its plus and minus points, and I have had the opportunity to work in many units. So from the All India Institute in 2001, I went for Narayana Hridayalaya, Bangalore, and had the opportunity to work with Dr. Shetty's unit. And I learned many things about patient management, about personal management in that place, and also many technical points, and then moved on to Fortis Escorts because my parents happened to be in Delhi. And we built an entire team out there, which has subsequently continued to move with us from into JP Hospital, into Apollo now. So basically a core group of 10 to 13 people have moved around with me. I've tolerated my idiosyncrasies, and hats off to them. Dr. Ashutosh was there, Dr. Vishal, Dr. Balli, who's our perfusionist, and Dr. Nitya. And I'm grateful to all of them for whatever we have achieved in this duration all together. And specifically, this is Bijinder Singh Bali. He's our perfusionist, and whenever there's a cardiac arrest, there's a call to him, and he's getting the pump ready, and I'm getting into the car and rushing into hospital. And Vishal is always there before. In JP, his house used to be closer, and his Mercedes used to be standing there before I reached there ever. So, and these are the people who have stood by me from for the last 15 to 17 years, and I'm grateful to them. And not to forget the nurses, an extremely helpful lot. Any hospital you go, they are very helpful. They go all out to do everything for your patients, and I have never had any complaints about any of them. My parents, they were very surprised about the line I chose. My father was a radiologist. He'd rather I became a radiologist, but I took up a line which he thought was very daunting and very difficult. So somewhere maybe, they're a little surprised, maybe they're a little happy also. They're and that, this guy is standing on this stage and, delivering a lecture to such a big audience. Most of all, this whole performance or delivery is indebted to this core group, which is my family of derivation, and that's my wife. And we came together in the same time as cardiac surgery, and I came together. And basically, she has basically supported me throughout this process. And also she has competed with cardiac surgery through all this time. So my wife and cardiac surgery have been competitors and have been supporters of each other also, because cardiac surgery stole my time from the family and vice versa. So it was always a competition between family and the patient, family, patient, operating room, vacations canceled, weekend holidays interrupted by the beeper, going back to ICU, because we used to be intensivists at the same time, as putting IV lines, re-intubating, operating, doing everything ourselves. Now, of course, the scene has changed. There are many cardiologists, many intensivists available today to take the load. And so the scene is much better today, but we were really, really busy, especially when I was learning surgery. And she stood by. She did all the different moving from one house to the other. Thousands of residences moved, all the bills to be paid. And now when a resident tells me that the tap is leaking at home and I cannot come, then I smile a little and say, it's okay, you go. But then within brackets, I'm telling him that, if you, maybe if you had some wife like my wife, maybe you would be able to, stick on to your work today and do the work that you're supposed to be doing. So, uh, and there is also Karan, my son, and he has always been my friend throughout and beyond his years, because I could never be the complete father to him because of this competition between the profession. And then yesterday KK was talking of the work-life balance, and he does not know what it is. Well, you ask a cardiac surgeon, that it's a continuous guilt trip in your brain that goes on between your family, between your patients, and it's you don't know which you're more guilty of, of the patients or the family, and ultimately, I guess you only end up losing from both sides, I suppose. So, it's not a simple life for a pediatric cardiac surgeon, especially if you're learning cardiac surgery when you have got a family. And so he was a friend to me throughout, despite my long absences. And I do not know how he grew up. I was staying in the ICU most of the time. And now when he's out, he's in the US now, and we talk for long hours. He's got interest in nature engineering, and we talk about long maybe an hour or 2 hours on the phone about how some operation is conducted, because he's done aeronautical engineering, and how the fluid dynamics and computer engineering and all that kind of stuff. So I'm deeply indebted to them, for standing by me. And what I am today is basically because of my family of derivation, more than anybody else. My in-laws, who supported my family throughout, because I was never there, and my wife was busy with her work intermittently, whatever she could take up in interrupted fashion. And they used to take care of the family when I was away. And I am indebted to them too for everything that they've contributed. Now, when I came back from the US, when I was working with Dr. Tandon, a lot of patients were referred to the South for cardiac surgery. And there were basically just one center in the North, maybe All India Institute. And there was another center, there were a few centers in the South, like Railway Hospital, Perambur, and a few other centers which were operating. And mainly these patients used to go to the South. So this was the cardiac surgery set up at that time, which was the 80s. When I came back in 1991, there were about a total of 10 pediatric cardiac surgeons when I truly became a pediatric cardiac surgeon on my own. And that till today, we now have a WhatsApp group of cardiac surgeons, which is about 150 to 160 strong. And it has really grown very well. However, as we know very well, the demand of the specialty is much more. We require to be doing so many more operations, but we do only about 23,000. And cardiac surgeons required are many more, but there are much less than what is actually required. And I've seen this slide ad nauseatum, and Dr. Anita Saxena's landmark paper. And this is the patient load that we have every year, and what we end up doing, 26,000 out of a possible 240,000, and the arrears keep piling up. And in this situation, we actually need to be building up our resources, building up manpower, building up infrastructure. And this is the present situation in India. If you see the dots, they look very concentrated. It's basically, I think, because the dots are bigger than not in proportion to the India's map size. But if you see the middle of India, it's basically vacant except for the Satya Sai Institute in Raipur, which is doing landmark work. And yet there is a big vacuum in Central and East India. In the middle of this, when there is so much requirement, there comes this. And this is an absolute shocker. If you see this, you cannot just help, it'll just take your breath away. 195 seats of CTVS, only 57 filled. Total CTVS seats in 2021, 206, only 74 filled, and all of them going vacant. Now, even this year, I think it is not really, not much better. And if this trend continues and is allowed to continue, I think we are going to see a very, very bad situation. The situation is going to be that cardiac illnesses are going to get diverted back to the West. And for example, when I was in residency, the patients used to go to Houston and get operated, to London and get operated, and now that doesn't happen anymore because I think we have developed the specialties well enough here, even though they have big waiting lists, and yet we are managing it. But if we go back to that time, back to those numbers, the situation is going to be that the government is going to have to spend enormous amount of money financing these patients because some loopholes will be there and people will find ways to get financed for all these operations to be done abroad. And it is going to be a big loss to the country. And the way the government has tried to handle it is by this means. They have reduced the enrollment percentage. And this is basically the way that this is the knee-jerk response of the powers that be to handle this problem. It is obviously not the right way to handle it, and you dilute quality, and you still probably will not get the people, the right people into the line. So therefore, I think we definitely have a problem. Cardiac surgery, and more so pediatric cardiac surgery in India, is in deep trouble, I think, if we are not able to get out of this situation. And it is extremely important. I mean, this topic has been talked about in this conference earlier and other fora earlier also. But I thought standing here as the president of this organization, if I speak of anything else, will be like Nero playing the fiddle when the Rome was burning. So it is appropriate, I think, to bring it up on a venue where both pediatric cardiac surgeons are there and both cardiologists are there, and we need to pay attention to this phenomena which is happening today. So I have a niece who did her MS general surgery, and she got into pediatric general surgery. She didn't take up CTVS, but anyway. So I asked her to get from her people, the people she knew from her colleagues, ask them why they do not take CTVS. Because in our country till now, mostly it is first you do CTVS and then you decide whether you want to go in for pediatrics or you continue to do both together. So it's first CTVS and then whatever else later on. So this was the result of the questionnaire which she gave to them. And the first reason the people gave was unreasonable working hours. So I'm split them into things that we can change and things that we cannot change, which are in our hands and which are not in our hands. There's a definite character to this specialty and we cannot change that. The unreasonable working hours are beyond our control, and therefore the second one is the monetary returns are not comparable with neurosurgery or oncosurgery. These are the popular surgical specialties today. And it takes time to build oneself up from scratch in CTVS. I've just put her reply down in verbatim. Third is few openings. So when they pass out, they do not see any openings which are up there to where they can go after doing this specialization. Independent practice is difficult. This is unfixable. This is an unfixable issue and is an inherent part of this specialty. It is a completely new branch, very different from general surgery. So it takes time to develop foothold in the branch. All true. There is little hands-on during the MCH training program. So this is absolutely correct. And I can tell you because I myself did most of my training, even though I spent 3 years in MCH. I did my first ASD in 1984, yet most of my practical training happened when I became a consultant with the help of my fellow consultants and my senior and the residents who would assist. And based on what the knowledge I had gained from my fellowships abroad, I learned when I had become a consultant, I was lucky to be able to stick on in this line with whatever family support or whatever I had. There are many who are not able to stick on with this and who just drop out, or who just pass out and who are totally inadequate. And if you don't get a job anywhere, or if you get a job in a corporate setup and you cannot deliver, then it's a big problem, because you have got a degree and you cannot do the operation reliably. So it's an issue. So this is absolutely true. Little hands-on during the MCS training program. This is the other thing. The other perception is that cardiac surgery is synonymous with coronary artery surgery. Now, pediatric cardiac surgery is a big unknown. Most people do not know about pediatric cardiac surgery as a separate line. So even if you ask a layman, they'll ask you whether, bypass surgery karte hain aap, and all. We will not know कि बच्चों का क्या होता है, बच्चों में भी होता है, कैसे होता है, all that kind of stuff they'll talk. So they don't know anything about pediatric cardiac surgery. So also the people in medical colleges, the students of medical colleges, they're not really aware of pediatric cardiac surgery, and especially in places where cardiac surgery is not part of the departments, or it is not where, it's not a big department where pediatric cardiac surgery is not being done, in its entire extent. They have little idea about pediatric cardiac surgery. So to them, if coronary artery surgery is going down, if more people are getting stented and then getting operated, which is, the news all over the place. So they feel that the coronary artery surgery is dying and CTVS is dying. So why go onto a sinking ship? Pediatric CTVS is cumbersome to do following MCH CTVS. So you do 3 years, it is 3 years or a 6 years course of CTVS, which is MCH or DNB, where little hands-on is given. And then you are asked to get into a fellowship program, which is another 2 years. And where again, the same cycle may be repeated of no hands-on training. So, because the people are the same, it's the same people who conducted the MCH, who are going to once again be your people who are mentoring you in the fellowship program. So what is the guarantee that at end of fellowship, you will be any better than when you entered the fellowship? And this is not acceptable to a lot of people today. And then the 6-year integrated course, which is the DNV program, which has come in CTVS. These people are just MBBS passouts. Forgive me because I'm just reading what she wrote. They have little to no knowledge about any super specialty branch. And if they don't have a family background in medicine or surgery, they are of the mindset that pediatric surgery and neurosurgery, which also have a 6-year course, are closer to general surgery, and they would rather take that rather than CTVS, which is a very different or difficult branch in their opinion. So this is the impression. And they are unwilling to apply for a pediatric CTVS program. There's one that exists in Rishikesh. There's a direct 6-year MCH, 6-year or 5-year, I'm not sure. So MCH program in Rishikesh, AIIMS, and they've started it, and they're unwilling to go into such a program because of the perception that pediatric cardiac surgery has a high morbidity and mortality. Now, this is the perception which is widespread among the students, and they are not an ignorant set of people today. They are not like us, who just fell for, something and then followed the line through right till the end, without any attention to any of the other details of their lives. Today's children are well informed. They have their mobile phones, which tell them everything about everything that exists under the sun. And they are informed about the training, what happens, about the number of openings which exist, about the life of a pediatric, of a cardiac surgeon after qualification, and basically nothing is hidden. So they take informed decisions today. And in my view, there are three possibilities that we can have for changing this scenario. One is that we have to set up more private units which will give paying jobs to these people, because the child of today, the pastor of today is expecting a good salary. He will work for peanuts, in some place. He wants a good salary because his peers are working in places which pay them very well for half the hard work that he does. So it is only a private hospital which is probably going to be the salary which he can aim at the end of some years of his career, and we can hope to get some money. Forgive me, but if I'm talking about money, but that is the reality of today, and that is the reality, actual reality, that you need to earn money to survive today. So what is happening in our hospitals today? So we have three sets of hospitals. We have the government hospitals, and we have the charity driven hospitals, and we have the private hospitals. Government hospitals there have been hospitals which have been set up in the All India Institute, like the All India Institute, but the salaries are limited, and people are still wanting to go into private setups. Now, private setups have people like me who are occupying the chairs for 35 years, and I'm still able to operate. And if nothing, happens, I will probably still be able to operate maybe for the next 5 years. So if one person is occupying a chair in a pediatric hospital for 40 years, and there's a fixed number of hospitals, then where is the opening for any new entrant who's going to come in? So that is an issue, and we need to set up new units of pediatric cardiac surgery all over the country. Now, the problem is that pediatric cardiac surgery the domestic population cannot afford the packages of these private hospitals. The government schemes are there, but the government schemes support only the packages they offer are not acceptable to the private hospitals, so they do not take up these these schemes. Even if they do take up, they do not end up making a profit, and it is not an incentive for them to set up more units. Therefore, they basically rely on international clientele, and international clientele also is compete. Hospitals are competing for international clientele, and it is also being limited because countries want to do the operation in their own countries because it is cheaper for them. So basically, that's not a long-term solution. So we need to tap into our 240,000 reservoir of patients, which is the strength of this specialty. It is a boon for the specialty that we have so many patients, we have so much supply, we have so much demand that needs to be met. One of the biggest problems has been that for the last 75 years of our country, we do not have medical insurance covering the middle class. All the government schemes, they cater to the lower socioeconomic status, and whenever you have a middle class type of salary, you are not eligible for these schemes. And unless you do some irregular means and you get a card or something, but that's not the right way to do it. So medical insurance prohibits the entry of children with congenital lesions into their purview, as if there were some other species, as if they're not human beings. And this problem has to be addressed. If we do not address this problem, this domino effect has already reached our specialty of people not coming in. So patients are not getting operated. We took up, and when we started, when we office, this executive board, and we have achieved a small degree of success, and I'll come to it in later. The other thing is that I think we need to have a separate specialization in pediatric cardiac surgery. This has to be a separate program after the MBBS. MS today is basically a laparoscopic subject, and more procedures are getting done laparoscopically. This is not relevant to CTVS today, and therefore we say that a person is going to general surgery and learn cutting and stitching, and therefore he should know stitching first and general surgery and then come into cardiac surgery. I'm not sure that's true. How many of us are going to be doing robotic cardiac surgery? So an MCH in pediatric cardiac surgery right after MBBS is a possibility and needs to be encouraged, and we need to watch how Rishikesh does, because Rishikesh is a path burner in this line. I used to be opposed to this concept, but I am absolutely for it right now, and I think that is the way to go. Pediatric cardiac surgery has to stand out separate from coronary artery surgery, from the synonym of coronary artery surgery, which CTVS stands for, and has to claim its own place in the in the line of different specialties. And people have to come and want to be pediatric cardiac surgeons in a line which is so demanding. And we have to create hospitals in this which cater to pediatric cardiac surgery by getting health insurance into this scheme. And I think these two things, if we can get these two things right, and if we can train our people who are coming to us for training properly and in a dedicated fashion, I think this tide could still turn, because you see the hall which is full today. I think I'm predominantly cardiologist, but then still a lot of surgeons. If you go to ISCTS, the halls are brimming. And you will see that, this specialties, people not coming in, doesn't matter. There's so many people. But you wait for 10 years, 20 years down the road when the next generation comes, then this number is going to start dwindling. And then there'll be no mentors. It's going to be a disaster situation. So I think the time to act is now. The thing to do is to catch them young. So recently I was doing a TAPVC, and this child was from Ludhiana, and the mom's brother, that's one of them, the kid standing there is the mom's brother, and he's doing MBBS somewhere. And that's the other one is his friend. They asked me, can we watch the operation? My usual response would have been, no, if you were not related, maybe I would have allowed you. I said, what the hell, So, this whole thing was there, about this people not getting into our line. So I said, let me take this thing differently. So I said, okay, you come in. I pretended to be a little reluctant, but I asked them to change and come in, and they watched the operation. Now, see how I got hooked into this line. A person who was basically a medicine man, whose brain was basically medicine oriented, getting hooked onto surgery. And I'm sure if these guys, taste blood, if they see how intricate and interesting these operations are, if they just read up a little of the pathology, the natural history, and how this line can change the natural history of sick children, I do not think there is a problem in getting these people. At this young age, they are still ideal. They're still idealistic, and they have their, they look up to things before money starts spoiling their brains as we get older. That's my belief. The other thing is this T-Rex phenomena. Now, what is this T-Rex phenomena? When they did the excavations, it's very interesting. They never found a juvenile T-Rex. So it is believed that T-Rex cannibalized his own juveniles. And that is a way T-Rex, Tyrannosaurus Rex got extinct, in addition to the other factors. In not training our juniors, our students, we are being T-Rexes. We are basically destroying their future. We are completely destroying this line. I think when we get somebody onto our line, we have assistants, or maybe even a pass out joins us in a fellowship or apprenticeship or the associate. It should be a done thing that in 3 months, this guy is going to open the sternum. In 6 months, he should be able to go on bypass. In 1 year, he should be doing ASDs and VSDs. There should be a definite timeline on at what time people can achieve what kind of operation. It has to be tempered with their abilities, with their attitudes, whatever. But in general, we have to train them. We have to train them like we would train our own kids, because this line, which has given us so much, which we have become what we have become because of this line, is going to just die, because if we do not let these people operate, and believe me, if you stand on the left side and he does the operation from the side, it's not different. If there's one difficult stitch, you take it to needle holder, and he's not going to refuse the needle holder. So you can put that stitch, but it is in his brain that he can do this operation. So he will do this operation later on when he's independent. He feels he can do the operation, then he'll learn from there. So it is very important that we stop this phenomena. And I know this phenomena occurs. It is easy for us to do the operation ourselves, but it is not that difficult. The feeling that you get by giving the operation to someone else and assisting somebody else to do, you're still scrubbed up, you're responsible, is a different feeling from when you do the operation yourself. It is a superior feeling, believe me. And which is the same thing, when we have people working with us, we should be ready to teach them. Each one teach one. If we follow this policy and we produce full-fledged, fully accomplished cardiac surgeons and one every year, maybe one every 2 years, and then take the effort to place this guy somewhere in the country, I think this is the way to go. So these are the 3 things I think that need to be followed. And I think we will see a difference. Many other points that were raised are uncorrectable, and they are part of this specialty. It is difficult. The training is difficult, and people who can only up to this line will come into it, and that's fine. We cannot go to the 0 percentile mode and take anybody who's not taken anywhere who to allow him to have him come here. So I think today pediatric cardiac surgery and cardiac surgery also is at the crossroads, and we need to be very careful about this, and we have to handle the situation very carefully, both with regards to insurance. And I would request everybody to pursue this insurance thing at whatever your level. You have to tell every parent that they have to advocate this. They have to question the insurance company. They have to question everything that which tells them that children cannot be insured, because now it has become ingrained into the DNA of people that they think asking for a pediatric cardiac surgery insurance to cover that is like, it's not possible, because it's something which is unknown and cannot happen. This feeling has to be changed. So every parent, I tell them now that you need to fight for this. The time to act is now. A few good things have happened by chance, as luck would have it. We got audience with the State Minister of Finance, and he happens to be a pediatric general surgeon. So he was very sympathetic, and he said that he took our document, the proposal that we have made, that basically that the insurance should be started from maternal and continued on to the child. And he has forwarded it to the IRDA, and the IRDA actually is sure enough within a few weeks issued this circular, and that circular has now reached all the companies we know, and they are supposed to take action on this. And we are basically trying to get an interview with the different companies and see if we can help them get this, because it has to be a win-win situation for both the insurance company and for the families. If the incidence of CHD is 1 in 100, and the enrollment happens at the inception of pregnancy or at marriage, there is no way that the insurance company is going to lose. There's one child who's going to require it. 100 people, 99 people, 100 people are going to pay for it. The only question is that they have to attract the people into this, getting enrolled into this kind of insurance. So it's got some coverage, and there's some WhatsApp activity also which has started. IAP, which is the Indian Association of Pediatrics, has also been trying on these lines, and we are all joining hands together to strengthen this movement. Finally, I would like to end by this quote, which is by Dr. Kothari. Resourcefulness of our patients makes them stoic, and resourcelessness of our patients makes them stoic and trusting, and that increases our responsibility several-fold. Thank you for your attention.